It's a pleasure to be here today. I have a lot of slides to go through and three topics I hope to cover. The first one is on the echocardiographic features or cardiac manifestations of chronic fatigue syndrome. The second one I'd like to get in, if I can, is the stem cell work we've been involved in over the past 18 months. And then hopefully toward the end I can show an example of the echo terrain map that we've developed using echo cardiography techniques. The Cheney Clinic is a specialty clinic for chronic fatigue syndrome and has been that way for about 20 years. We've seen about 8,000 or so cases from 48 states and 26 foreign countries. Presently, we see patients from actively from 26 states and 7 foreign countries, of which almost all of the English-speaking countries are represented, I think, except New Zealand. And the patients from Australia probably outnumber all the other non-U.S. English-speaking countries, and some of them are actually in this data set. These are the key ideas I hope to cover. One is that chronic fatigue syndrome seems to be linked to a problem with oxygen handling. I'll simply call it oxygen toxicity for want of a better word. It is simply they have trouble handling oxygen, and you can see that readily on echocardiography. Chronic fatigue syndrome is heavily linked to diastolic dysfunction. Diastolic dysfunction is a condition the heart is in when it has an energy problem at the cell level. In other words, if there's a cellular energy deficit, it will express itself as cardiac diastolic dysfunction. And that's what we see in almost every case. It sort of depends on what particular parameter you choose to look at as to what percentage you'll get. We want to identify an particular echocardiographic parameter called the IVRT. It stands for isovolumetric relaxation time. It's an interval measurement in milliseconds between aortic closure and mitral opening. And it's essentially a measurement of the time it takes the heart to use all available free energy to pump calcium out into the sarcoplasmic reticulum, allowing relaxation and filling, F-I-L-L-I-N-G, to occur in the ventricle. So, in other words, IVRT is an indirect measure of the free energy of the system, and it's inversely related. That is, when IVRT is prolonged, the internal energy, free energy, is low, and when IVRT is short, the free energy is high. So that gets a little confusing when we say it's IVRT is positive. That's a bad thing if it's shifting positive because it's prolonging. If it's shifting negative or getting shorter, that's a good thing. And I'll try to point that out as we go through this. I've been enamored with the free energy equation by Willard Gibbs, who actually won a prize from the United Kingdom many years ago. In fact, he won this prize before the Nobel Prize was in existence. It was considered the Nobel Prize of the day. I think it was called the Victoria Medal, I think. But he was considered to be one of the greatest American scientists for coming up with this interesting equation that says that free energy, G, is related to the enthalpy of the system, which is the bond energy available to make ATP, but you subtract the temperature, or you might say the metabolic rate of the system, times an entropy factor or a chaos factor, which I have begun to interpret as reactive oxygen species or redox instability in the system. The nice thing about Gibbs is that his equation was responsible for 3 Nobel Prizes, and the Nobel laureates all pointed out this equation as being fundamental to their work. I like to show that CFS is really an unstable redox state, as demonstrated by echo terrain map, and hopefully I'll get to that, and then we'll talk about stem cells at the end. As mentioned before, there's a case definition. The one applied in this work is the CDC 1994 case definition with all of its flaws that Dr. Linda Jason pointed out, and I agree with all of that. But what's interesting to me about this disease is I don't think it takes rocket science to figure these patients out in the clinic. We sort of, I was always mindful of the time in Lake Tahoe when these patients got around a round table, and would talk to each other. And as they talked with each other and talked with each other and talked with each other, suddenly their eyes got brighter and they became more interested in what they were hearing and began to realize that they all had the same thing. And so the question is, what is the drum roll that they're hearing that made them feel like they belonged at the table? And you could take other patients with different diseases. You could take MS patients or lupus patients or depression patients or some other disease, put them at the table. It would not take them more than about a minute to figure out they were in the wrong table. I want to get up and leave. And what you're hearing here is I have an energy problem, but not only is it a fatigue problem, they have a problem with dynamic function. That is, they push and then they crash. They have a post-exertional fatigue component that's very profound, and this dynamic character of their fatigue is seemingly lost in the description of fatigue. It's not fatigue. It's fatigue in which the person pushes and then the patient crashes in the days after that. That's what they're complaining of. And they complain of brain function, primarily subcortical difficulties of complex processing. And then many of them, or actually most of them, but interestingly not all of them, will complain of pain because 5% do not seem to have significant pain in my experience. None of those 5% would meet the 1994 case definition, which has 5 elements of pain and requires at least 4 to meet the case definition. So that's another big flaw in that case definition. Cognitive disturbances are seen in virtually all of these patients, and they're processing in nature or subcortical in location. They involve processing speed, short-term memory, especially auditory, sensory, and information overload, word searching, multitasking, and spatial organization. A very characteristic of this illness, very profound in some of these patients, and can be the number one complaint that we hear. There are mood disturbances seen in 60% of cases as documented by neuropsychiatric testing, primarily depression, which I find to be very rarely severe in this illness. Anxiety spectrum disorders, I think, far more common in my experience, and then mood lability. But the 40% that don't have any of this look exactly like the 60% that do with respect to those primary symptoms. There's both a symptom dysfunction, what I would call the misery component, and then there's a dynamic dysfunction, I'll call it the action component. In the beginning of the illness, it seems to have more of a misery component to it, symptom component to it, but function sometimes isn't that affected. And then as time goes on, the misery component seems to contract somewhat, and the dynamic dysfunction seems to expand. And so as these people evolve over time, and they do evolve, they don't look the same in the beginning as they do in the middle, as they do at the end. They end up with, interestingly, a pretty significant control of many of their symptoms, but absolutely no function. This sort of describes some of the evolution of the illness. The phase 1 is so-called onset or trigger phase, which can look flu-like, mono-like, encephalitic-like, nonspecific sorts of viral onset. Phase 2, the triad phase, is my energy shot and I have a dynamic problem with energy functioning. My brain is shot and I have pain. And then they enter this long dynamic dysfunction phase in which they seem to be trading function, losing it to control symptoms. And there may be an adaptation phase in which people claim that they're recovered from this disease. I'm not so sure they ever really recover from this. They simply become very good at adapting to it in complex ways, and they seemingly are recovered. You can plot this on a misery axis on the y-axis and on a limited axis on the x-axis. Starts out as a very miserable disease with not much functional impairment, and then it evolves to still a very miserable disease and a lot of function problems, and then it evolves to much less misery and a whole lot more function problems. And it's sort of interesting to speculate, well, why do they have so much dysfunction even when they're controlling symptoms? And I'll present some evidence of an underlying cardiomyopathy. There certainly may be an encephalopathy. There certainly may be DNA phenotypic and genotypic adaptations occurring. In terms of the probability of a functional recovery or perhaps successful adaptation, depends on the length of illness. And in the first few years, you can see quite a high percentage of people that seem to recover in our experience. But as time goes on It's a declining probability curve of functional recovery and or functional adaptation. This is some of the first data that we did using exercise ergometry, suggesting there's a defect in oxygen utilization, which would certainly be able to affect energy. So this is a 25 age and sex-matched controls against 25 age and sex-matched patients. And as you would expect, the controls ended up sitting at about 100% of expected oxygen consumption in cc's per kilogram per minute. This is actually expressed as percent of predicted. Our patients were coming in at about 2/3 of that number. You'll notice these couch potatoes right here, or the so-called deconditioned crowd. It's very rare for deconditioning to drop you below 75% of the V.O2 max predicted. And these patients are generally well below that. And such that it's not likely that this is due to some deconditioning, but some serious flaw in utilization of oxygen and therefore energy production. Another example of potential problems in energy production can also be seen in the brain. This is from Cornell using the 3.0 Tesla coil. Almost double the strength of most MRI scans. And this is looking at voxels within the third ventricle, and you can see this lactate peak present in almost 70% of the patients that we sent up there. And if you integrate under that lactate curve, you'll see that chronic fatigue syndrome is much higher than any other thing they've looked at other than specific mitochondrial genetic defects, which can be higher. Interestingly, generalized anxiety disorder is a little bit higher than control groups, but not nearly so high as the chronic fatigue syndrome. Suggesting, again, if lactate is elevated in the brain, it could either be a hypoperfusion of the central nervous system doing that, or an injury to aerobic functioning, and therefore shift to anaerobic metabolism and a buildup of lactate in the CSF fluid. This is the fingerprint problem that we began to look at. I can remember the day the patient came to me, and she said her fingers felt like someone had sanded them down, and they felt funny. And I said, well, let me look at them. And I looked at her fingerprints, and they weren't there. They were completely gone. And the fingerprint destruction has two characteristics. It's got this deep crevicing or scarring. It also has a smoothing out of the ret ridges. Sometimes it's all smoothing, and sometimes it's mostly this characteristic destruction. But they cannot be successfully fingerprinted, and they go through all kinds of trouble, by the way, when you can't be fingerprinted. I did ask a deputy sheriff one time, how often is it in law enforcement that you cannot get a fingerprint? And he said, almost never. And I said, well, that's interesting, because almost never occurs a lot of the time in my clinic. When we biopsied 16 of these and sent the punch biopsies to UNC Chapel Hill for their dermatopathology examination, we found two characteristic defects. This shows one of them. There's perivascular lymphoid infiltrates, or perivascular infiltration of the intimal tissue, probably cuffing this micronutrient vessel off, and so there's some degree of impairment of microcirculation and an inflammatory response, and I think may be responsible for some of the scarring that you see. The other slide I have, which I've somehow lost that slide, is they described punched out lesions in the fibroblasts, which would impair fibroblast function in the laying down of collagen and may therefore cause the smoothing and the loss of the ret ridges. The other major disease that causes punched out lesions in the fibroblast is scurvy, a deficiency of vitamin C, and or a problem in the control of the redox state or significant oxidative stress. So I think this fingerprint may say more than it seems. It may say there's an element of immune activation in this patient. There's also an element of severe oxidative stress in the system. A seminal moment occurred in sort of post-outbreak in Lake Tahoe in 1985 when Dr. Soldonic began to show us data on problems with this RNA cell pathway, which is a part of the innate immunity pathway, primarily against intracellular viruses. It's initiated by interferon, which activates 2,5-A synthetase. It converts ATP to 2,5-A, sits down an RNA cell, activating it, and it goes around chopping up RNA in the cell, degrading both hopefully viral RNA, but unfortunately when it's unregulated, it can also have a big impact on human RNA and human function. This pathway turned out to be very important in our belief that this was probably of viral origin, and also came about to be important, I believe, in Judy Mikowitz's discovery of XMRV in this illness. So, this is one of Dr. Soldonic's slides, and I will always remember this. When it shows the mouse ribosomal targets, which breaks into a 28S and an 18S subunit, and these molecules are migrating from top to bottom based on molecular size. So the smaller ones migrate further, and the bigger one migrates less far. And flanking this is the typical RNase activity in normal lymphocytes. So if you take normal lymphocytes and you extract their cytosolic RNA cell, they will and incubate them with this ribosomal RNA target. They will digest, as you see, most of the 28S, seemingly leaving the 18S alone, and then you get these cleavage products that are smaller and therefore migrating further down the gel. And so this is typical normal RNA cell activity, relatively and probably regulated. Over here are a bunch of CFS patients. This one looks pretty normal, but as you look at these other gels, you get to this patient right here. This patient has nothing on the gel, and when Dr. Soldonic saw this, he said, wow, maybe I did the experiment wrong, and he tried to back up the incubation time and realized it was actually real. The RNA cell activity was so great in these patients, they were actually digesting the 28S, they were digesting the 18S, they were even digesting the cleavage products into tiny pieces migrating completely off the gel. The highest RNA cell activity he had ever seen in any disease, anywhere, at any time. When we saw this, I remember the hair on the back of my neck stood out as I thought, you know what, this is one hell of a disease that can do that, because you can imagine what this would do to intracellular human RNA if it's digesting things like that. XMRV, a novel human retrovirus discovered in 2005 at the Cleveland Clinic in prostate cancer. And one of the driving forces for looking for this was an RNA cell antiviral immune defect present in these cancer patients. And it was thought that perhaps that RNA cell defect was responsible for the perhaps heavy load of XMRV in these cancer patients, allowing it to be discovered in the first place. Since then, it's been found in 67% of the blood, peripheral blood of chronic fatigue syndrome patients. It's been found in 18 to 44% of prostate cancer tissue, depending, interestingly, on the relative aggressiveness of the cancer. The more aggressive the cancer is, the higher the rate of XMRV infection. The less aggressive, the less chance of finding it. It's been seen in up to 10% of transplant patients who have upper respiratory tract infections, recently published out of Hamburg in Germany. In terms of apparently healthy controls, it's been found in 3.8% reportedly in healthy controls in the Science paper by Lombardi and Mikowitz. It's been reported to be found in 3.2% of the sputum and nasal swabs of 67 healthy people in Hamburg, Germany. It's been reported to be found in 6% of benign prostatic tissue in the U.S. in Salt Lake City. What's important about these three papers is that if people cannot find XMRV in the control groups, then they may not be able to find it in anybody. So it's important that they find it in the controls, because it's in the controls, and if it's not found in the controls, then their assay is not sensitive enough. This is our results in basically the fall of 2009 up through the beginning of 2010. Consecutive patients, 47 tested using an amplified culture technique, not PCR. This is, I think, far more sensitive than PCR for this low copy number virus done at VIP Diagnostics. It was 81% of this consecutive 47 patients tested. Some of the notable findings was that the male to female ratio for XMRV positives versus negatives was identical. 50% of all family members with a CFS case were XMRV positive with an N of 6 family members tested. Many family units suspected subclinical illness in other family members based upon symptoms. One mother, daughter, and son threesome with CFS, all XMRV positive, all became sick in Prague, Czechoslovakia, some 17 years ago. One father and daughter pair with CFS, one with XMRV positive. One father and son pair with CFS. One mother and son pair with CFS, both XMRV positive. One mother and son pair, mother has CFS, son has autism. One mother, son, and 2 maternal uncles, all with CFS, mother and one uncle, her brother, are XMRV positive, suggesting, especially the finding of 50% of family members with one case being positive, suggested that this virus may actually be transmitted rather easily in a family setting. Is there a cardiomyopathy in chronic fatigue syndrome? Heart failure is very common. It affects about 5 million cases in the U.S. There are 500,000 new cases every year. The leading cause of hospitalization, interestingly, for those over 65. 66% die in the first 5 years after admission. 24% die in the first year after admission. And this is the shocker, is that over half now of all of these massive admissions only have diastolic heart failure. That is, they have no impairment of left ventricular systolic function. Their systolic ejection fraction is completely normal. Yet, they are a rising tide of admissions for heart failure for reasons that are uncertain. This has been reported to be in a non-scientific poll to be, interestingly, among one of the major causes of death in chronic fatigue syndrome. Heart failure has about 4 major symptoms. If it's systolic heart failure, there's a lot of dyspnea, particularly orthopnea and P&D, problems with shortness of breath on laying flat, requiring some pillows to prop your head up, exercise intolerance, fatigue, and weakness. What's interesting about diastolic heart failure, or its brother here, diastolic dysfunction, which can occur decades before diastolic heart failure occurs, the primary symptom of that, and somewhat different than systolic heart failure, is interestingly orthostatic intolerance. People with diastolic dysfunction cannot stand up for very long. And the reason is if you have a filling problem, F-I-L-L-I-N-G, at the heart level, it's very difficult to stand in a gravitational field because you have additional gravity-related filling problems. So you have a double hit when you stand up. So orthostatic intolerance is the clinical clue to diastolic dysfunction. Exercise intolerance, fatigue, and weakness sounds very much like a lot of the patients that I see. There are many types of tests to measure for cardiac output. The FIC method, which is not terribly invasive, dilution method, which is invasive, impedance cardiography, which is non-invasive, Doppler ultrasound, which is non-invasive, and the brute force method, which is simply to take the pulse pressure times 2 times the heart rate. This can be occasionally okay to use. I don't find it to be particularly accurate, however. Our first experience in looking at cardiac output was following the paper published by Peckerman and Nadelson in 2003, in which they showed that compared to controls, both in the supine position and in the standing position, controls had significantly higher output than these patients, or patients were much lower. And when they stood up, both went down. But what's interesting about CFIDs is they go down far enough to be at the point where they could have perfusion organ system problems when they're standing up that could be quite significant. When we first saw this, at first I didn't believe it because I just come back from major surgery for heart failure myself, and I knew what heart failure was like, and I knew it wasn't like what I was seeing in my patients. And so I thought this paper was wrong, but I was intrigued. And so we got some research equipment similar to this used in this paper, and we repeated the data in our patient population. And our patients were actually much worse than reported by Peckerman, probably because our patients just tend to be sicker than patients that end up in an academic center. But I was now convinced that there was a real problem with cardiac output, but asked the simple question, why is there a problem with cardiac output? What's driving this? We took the patients with the lowest cardiac output, and we had them echoed in 3 different places around the U.S. We got the same, the results almost on the same day, and they all said the same thing. They said normal left ventricular function, normal chamber sizes, normal valve function, but at the very bottom it said, but type 1 diastolic dysfunction for all 3 of them. And I was sort of shocked because, first of all, I didn't know what that meant. And second of all, I didn't know why I didn't know what it meant. So I called up a friend of mine who's a cardiologist. I said, Dick, why don't I know what this means? And he said, well, it's a new term in cardiology. It was probably first discovered in 1995, and therefore any textbooks prior to 1995 would have no mention of it. And then the instruments to measure it really didn't come about till about 2001. And so I'm talking to this physician about 2004. So really, it really had only begun to hit the literature in the last few years. And I said, well, okay, Dick, that explains why I don't know what it is. I wouldn't be expected to know what it is, but what is it? And he said, well, it's what the heart looks like when there's no energy in it. And I said, would you repeat that? I want to make sure I heard you right. He said, that's what the heart looks like when there's no energy in it. And I said, wow. So we called General Electric and had them bring in one of the advanced echocardiographic machines called a Vivid 7, and we demoed that model with 6 patients, and this was in the summer of 2005. And after the 6 patients, the echo sonographer turned to me. He was a GE sonographer from Orlando, Florida. He said, my goodness, I have never seen diastolic dysfunction so severe in a group of patients this young. May I ask, what's wrong with these people? And I said, well, they have chronic fatigue syndrome. And he said, what's that? So we knew we were onto something, so we went ahead and bought this machine and began doing echocardiography. And we've done 5 years worth of echocardiography virtually every day for 5 years, and many nights I've laid awake trying to understand what I saw the previous day. So it's always been like a super fellowship in echocardiography directed at diastolic dysfunction. This is an example of how you can detect or measure the cardiac output. You simply see the aortic outflow tract, and you just take your little mouse and you integrate you're looking at time on this axis and velocity on this axis. You're looking at the time rate of development of the velocity of the ejection through the aortic valve into the aorta, and you integrate that, and out pops the stroke volume, which is sitting here at 124 cc's of stroke volume. You then calculate the timing of this, and that generates the cardiac output, which you can see here at 8.3 liters per minute. That's quite normal. After doing this type of echocardiographic output measurements in 50 consecutive patients, and then dividing by their body surface area to create a cardiac index, which converts the raw cardiac output and corrects for size. Big people have bigger cardiac outputs, and smaller people have smaller cardiac outputs. So the cardiac index helps correct for size. So you can sort of compare, or just you can analyze all the patients stuck together regardless of size. And then we plotted them on this Guyton textbook of medical physiology where they sat in respect to other diseases that affected cardiac output, either made it higher or lower. Hyperthyroidism is higher, anxiety is higher, pulmonary disease is higher, hypertension is higher, myocardial infarction is higher, Mild shock is higher. CFIS kind of sits in here. Traumatic shock is lower, and cardiogenic shock. There are people, basically those below 2, that would fit very well into a transplant ward awaiting cardiac transplant. That's how low their cardiac output is. When you do this, analyze this statistically in an age and sex match, 15 patients and 15 controls, age and sex match, it's really quite dramatically different. The controls are sitting up here around 85 cc's. The patients are sitting up here at about 55 cc's for the stroke volume. If you look at cardiac output, it narrows a bit, although still statistically significant. And the reason it narrows a bit is that the heart rate is somewhat higher in these patients than in the control group. And so what's happening is as the stroke volume declines, they try to make up for the loss in output by simply beating faster. There are 2 types of heart failure, of course. There's systolic heart failure, failure to eject, associated with coronary artery disease and idiopathic cardiomyopathy. There's diastolic heart failure, or failure to fill, associated with hypertension, diabetes, energy deficits, acute and severe stress, typically in the elderly themselves, especially those over about 75 years of age, and associated, interestingly, with the female sex. Systolic heart failure is typically a failure of the muscle to function for any number of reasons. Diastolic dysfunction, however, is a failure of sufficient free energy, G, to pump enough calcium out fast enough for the myofibrils to relax well enough to fill. So this is an energy-related problem, and it's not intuitive, because you would think the squeeze is the energy, but it's not. It's the relaxation. The energy is pumped into the system by creating a calcium gradient using the available free energy. And when the calcium is all on the outside and there's an EKG signal to depolarize the membrane, the calcium then rushes in on its gradient, binds to a troponin, it goes through a conformation shift, and then the myofibrils come screaming in as the ventricle contracts. So the ventricular contraction is the release of energy, but relaxation is actually when the energy is being pumped into the system. This is a paper that's published in the New England Journal of Medicine from the years 1986 to 2001, and they plotted the difference between preserved ejection fraction heart failure, which was quite low in 86, compared to unpreserved ejection fraction heart failure, the typical type of systolic failure that you would see in heart failure admissions. And in this 15-year period, the systolic heart failure was declining relative to the diastolic heart failure, which was rising with very large numbers, and they had no explanation for this reversal of these 2 different types of heart failure, which is really quite extraordinary. Well, how do you diagnose diastolic dysfunction? There are 3 major ways to do it. The classic way is to point the transducer at the mitral valve and look at the filling E wave, E for energy, as it were. It's energy dependent. And then the A wave is the atrial contraction, and the 2 pulses of blood passing through the mitral valve from the left atrium into the left ventricle fill the ventricle with blood, available as the stroke volume when it squeezes. So you fill early or fill with energy, and you fill late by atrial contraction. Normally the ratio is about 1.4. In type 1 diastolic dysfunction, they're reversed. The E wave is somewhat lower because there's less energy. You compensate by having the atrium squeeze harder to make up the difference. And that is why one of the earliest signs of morphological changes in diastolic dysfunction is the left atrium gets bigger and bigger and bigger. It dilates under this heavy load of having to compensate. And as it dilates, one of the first things that can happen is a variety of atrial rhythm problems and eventually perhaps atrial fibrillation. In advanced diastolic dysfunction, you see the atrium basically die, and the atrium doesn't work very much anymore, and the ventricle is really struggling to try to fill artificially by squeezing really hard, and then on the relaxation, rebound, suck blood out of the left atrium, creating this pretty high E velocity. And if you see this, you basically have 5 years to live. That is not a good thing to see on the echocardiogram. Fortunately, we haven't seen anything that looks like this in my cohort. Another way, which is more sensitive, is to not look at blood flow, but look at tissue Doppler. In this, you aim this at the annulus of the mitral valve, and you're looking at tissue movement as opposed to blood flow, and it goes in the opposite direction. And so you'll see the E prime movement, which corresponds to the E wave in blood, and the A prime movement, which corresponds to the A wave of blood. Remember, it's going in the opposite direction, so it's negative. And this is normal, and this is the reversal of that. And if the E to A is normal, but this is reversed, we call that pseudo-normal. And it is the most common presentation of typical parameters in the chronic fatigue syndrome. The third way, which I like the best, because it has a unique aspect to it, is the pulmonary vein inflow, which has an S wave, which is the right ventricle squeezing, sending blood through the pulmonary vascular tree to fill the atrium on the systolic side. Then this corresponds to the E wave filling, and then when the atrium contracts, it actually sends blood back up the pulmonary vein in the opposite direction, so the A wave here is sort of reversed when you're looking at the pulmonary vein. The beauty about this one is that you're not only looking at these two diastolic parameters, you're looking at, and this is interesting, the systolic compensation for a diastolic problem. And how does systole compensate for diastole? The answer is it squeezes the hell out of the ventricle. That's the answer. So what happens is, in diastolic dysfunction, you'll see a big increase in the S wave as you see this big decrease in the D wave, and the A wave becomes broader. And this particular waveform, in which you look at not only at the diastolic problem, but the systolic compensation, so you're looking at both the problem and its compensatory, is by far and away the most sensitive parameter for diastolic dysfunction, and seen in terms of D to S reversal in a whopping 97% of my patients. This is kind of what it looks like. This is normal. Here's the E wave, sort of early fill, then late fill. You can see the E wave dominance. This is a CFS patient with diastolic dysfunction. See the smaller E wave and the larger A wave. That's E to A reversal, classic type 1 diastolic dysfunction. This is tissue Doppler, which is actually my favorite. It's really pretty to look at. They use a different frequency, and it has a different characteristic. But you have an early fill, late fill, then the systolic ejection through the aortic. And if you integrate underneath that, you're kind of looking at the stroke volume. Look at this patient over here, CFS patient. They have notice the E prime is smaller, the A prime is larger, and you notice if you integrate it under the aortic outflow, it would be lower than this. You're seeing the effect on the stroke volume of declining filling of the left ventricle. This is the pulmonary vein. This is normal, a small S wave, a big D wave, and a little tiny A wave is normal. This patient has a much bigger S wave, a much smaller D wave, and then a wider and somewhat shorter A wave. That's D to S reversal, the most common finding. And what's difficult about this particular type of analysis is you have to have a really good machine, because you have to shoot the Doppler pulse all the way through the heart. You have to shoot from the apex or base of the heart all the way through to the pulmonary vein. You have to shoot all the way through the heart. And so only the better machines are able to acquire these signals. We were fortunate to be able to get a very good machine right off the bat, or we could have even missed this. This is the atrial cavitation, so-called, which is truly impressive and gives rise to one of the major complications of diastolic dysfunction in the chronic fatigue syndrome. You'll notice in this two-chamber short-axis view, see right here is the left atrium, and the left atrium is pictured as the ventricle is contracting and sending blood out the aorta. So the atrium sitting there with a closed mitral valve, and it's filling up with blood, and it gets its maximum dimension. What happens is, if you take a patient in a supine position and then you stand them up at 70 degrees, unbelievably, the left atrium absolutely pancakes. The atrium collapses. We don't see this kind of collapse in normal people. It usually collapses below 23 millimeters. You just don't see that in normal people. It happens all the time in this disease. The consequences of a left atrial cavitation is that if it cavitates like that, that means the pressure is lower. If the pressure is low on the left side, then you can blow through a foramen ovale and create a hole in the heart called a patent foramen ovale, which we would find later. Very important to see this. It also led to another discovery because I was typing into Google. What a wonderful device, by the way, typing into Google left atrial cavitation, and out popped a paper. But before I get to the paper, let me just say I went through 50 patients in this age range and matched them to controls. I was asking the question, if I match the patients to controls, which of these parameters is the most specific and which is the most sensitive? And what we found is the E to A ratio was not so sensitive, nor particularly specific. The E to A prime or tissue Doppler was a bit more sensitive, but still lacks some specificity. The LL cavitation was very specific, but not terribly sensitive. And this so-called E to E prime parameter had the greatest degree of sensitivity and specificity and we just sort of wanted to ask the questions, what did this look out like in a case control study? When we expanded to 70 cases, we found that E to A reversal was seen in 43% of these 70 people, E prime to A prime reversal in 60%, E to A or E to A E prime at 71%, D to S reversal, which gives you the advantage of looking at diastolic dysfunction and the systolic compensation, a whopping 96%, and one or more of the above 97%. If you head up tilt these people and put them in 7 degrees head up tilt and repeat this, it's 100% positive for diastolic dysfunction because you're bringing out the diastolic dysfunction by adding a gravity filling problem. There's a big problem in the left ventricle as well, and you can see normal people, normally during diastole, they're relaxed, and the interventricular septum measures only about 8.5 millimeters right there. When they contract, their interventricular septum will squeeze up to about 10 millimeters, about a 22% increase in the thickening of the muscle when they squeeze. In chronic fatigue syndrome, it's much more impressive. They're sitting also at about 8 millimeters doing diastole, but when they squeeze up to 15 millimeters, almost a 70% increase. And that big squeeze around the ventricular muscle results essentially in ventricular collapse. It cavitates, and the ejection fractions can approach 85%, particularly when they stand up. So there's significant pressure on the left ventricle as it tries to compensate for diastolic dysfunction. This is some of the statistical analysis in this age and sex match cohort to just look at the differences in that interventricular septum, which is significant. And then we applied the so-called tissue synchronization technology, which is a high-end aspect of echocardiography, in which you can look at the ventricle and you can pick out different points from the interventricular septum here, yellow, blue, and red, and you'll follow these 3 different points to see if they're in synchrony. And you'll notice this is the E prime early fill, the A prime late fill, then the systolic ejection. And you'll notice that all 3 colors are coinciding and therefore they're in synchrony. However, in chronic fatigue syndrome, if you look first at the yellow and the blue, they look like this one, but notice the red is 500 milliseconds out of sync, which means when part of the ventricle is still filling, the other part of the ventricle is actually trying to squeeze. This is called ventricular dysynchronization. It has a tremendous and negative impact on stroke volume, even worse when they stand up. Secondly, this is completely eradicated in seconds by the administration of sublingual magnesium. Magnesium almost instantaneously corrects this dysynchronization. Also looking at strain patterns, normally the ventricle strains in a normal fashion, it's red. When this patient was tilted upright, in which the ventricle comes under stress, and then tilted back down, we saw this little blue line. See this blue line here compared to no blue line over there? That blue line means subendocardial ischemia has occurred in the upright position. And of course, one manifestation of subendocardial ischemia is chest pain. This is a key article because when I typed in left atrial cavitation, out popped this article. And it said that when you took 8 healthy young men and put them in a hypobaric chamber and mimicked a climb to Mount Everest, about 24,000 feet or 8,000 meters, they all sustained this type of echocardiographic shift at high altitude where there's less oxygen. And what you're seeing here is an exact listing of everything that we've seen diastolically in chronic fatigue syndrome. It's exactly what I see in all of my patients. And it was created simply by an altitude experience. If you will, a lack of oxygen was recreating the diastolic dysfunction. I had an epiphany at that moment, and I was quite excited. I said, wow, they just don't have enough oxygen. And when we give them oxygen, something really good will happen. And if you look at this guy sitting on Mount Everest, you'll notice he has a faceplate on, and he's actually breathing oxygen. If he wasn't breathing oxygen, he'd have severe diastolic dysfunction. But if he puts the oxygen on, it just goes away. So we took our patients, and using all the diastolic parameters, but particularly the IVRT, which again is the distance from aortic closure to mitral opening and measures the internal free energy of the system. Well, to our shocking surprise, when we administered oxygen, all the diastolic dysfunction parameters did not get better. They all got significantly worse, every single one of them. And in particular, the IVRT got worse. This is a patient sitting at 100 milliseconds right here. That's elevated. It should be less than 75. This patient sitting at 137 milliseconds. That's very high. And these patients have significant free energy problems in the myocardium expressed on IVRT. If you then look at all of these 92 patients, 97% are above the considered normal barrier at 75 milliseconds. 79% are above 85 milliseconds, and a whopping 34% are above 110 milliseconds. By the way, at 150 milliseconds, you have about 5 years to live. You don't live past 150 milliseconds. The heart can't stand that much loss of energy. This is a patient at baseline with a 92 millisecond IVRT. Upon the administration of 4 liters of oxygen, that IVRT jumped out to 111 milliseconds, or a 21% loss in free energy simply with the administration of oxygen. Again, we talked about the left atrium collapsing, which creates a pressure gradient. And if you look at the PFO, the foramen ovale is created by 2 structural elements, the septum secundum and the septum primum. And these normally are open in utero, and when you take your first breath, the oxygen hits the lungs, the pressure drops on the right side, and these 2 structures come together and close and seal in most of us over the first year of life. However, in these particular patients, we used saline bubble injection technology, where you inject saline with some microaerosolized bubbles into the antecubital vein, and they'll pacify the right side instantly. If there's no hole in the heart, the bubbles will stay on the right side. But there's a PFO right here, and it's beginning to coming through into the left atrium and hasn't appeared in the left ventricle because the mitral valve is still closed. And this is a time sequence of a patient in which we put the bubbles in, they'll pacify the right side, passes through the PFO into the left atrium. When that mitral valve opens, all these bubbles are now on the left side of the heart where they should not be unless there's a hole in your heart. So something is blowing open the foramen ovale in these patients. And the percentage of this stands at almost 90%, and there's lots of false negatives using this technology. So we think that what's happening is that ventricle over squeezes to protect and defend against the loss of stroke volume and maintain output. As it rebounds elastically, it sucks blood out of the left atrium. Left atrium collapses, and you get a pressure gradient that rips that previously sealed foramen ovale, creating a hole. The primary complications of this PFO are twofold. One is increased incidence of stroke that could produce the tiny lesions we see in the MRI scans of these patients, and 2, it creates migraine and severe headaches, which we also see. I think Well, in analyzing what happens to untreated patients at 4 liters per minute, they're almost all toxic to oxygen. If you start to treat them with various algorithms, improving algorithms, you begin to see the rate of oxygen toxicity decline to the normal range. There are about a third of normals that are toxic to oxygen. And the problem here is that almost all of my controls are exposure controls to CFS patients. And of the 2 people I've tested here that are oxygen toxic are also XMRV positive. And so we have a hypothesis that we would like to test, and that is whether oxygen toxicity is a biomarker for XMRV infection, even in those who don't have chronic fatigue syndrome. If you bump it up to 10 liters per minute, virtually all of them are toxic to oxygen. And then with the best treatment, you'll see it approach this control value. Conclusion. At 4 to 10 liters per minute of nasal oxygen, chronic fatigue syndrome is an oxygen toxic state with almost no exception. 1/3 of controls can be mildly toxic to 4 liters. 2/3 of controls are tolerant or responsive to oxygen at 4 liters per minute. And I think I'm probably going to have to stop there.
Yes, please. Thank you. Thank you, Paul.